think. Hello? Hello?
Now we can hear you. Please proceed.
Okay. Good evening, my dear professor and colleague. First, I would like to thank our scientific committee and organizer for such successful scientific gathering. Now, we will start a Lily Symposium touching a very important topic related to CDK4/6 inhibitor. It's my honor and a pleasure to introduce my dear colleague, Nawal Tuhemi. Nawal is a consultant of oncology, clinical oncology in Electricity Hospital. Her talk will be CDK4/6 inhibitor data changes practice in management of hormone positive, HER2 negative metastatic breast cancer. Dr. Nawal, the floor is yours.
Thank you, Dr. Lubna. I'm really honored to join Ain Shams University Clinical Oncology Department Conference, the department where I have learned and I start my first step in oncology. Thanks, Lily, for giving me this opportunity, and I'm so excited because I'm going to talk about one of my favorite drugs, CDK4/6 inhibitor. My topic will be about CDK4/6 inhibitor data changes practice in management of hormone receptor positive, HER2 negative, advanced.
Please make the presentation full screen.
Okay, I will. Is it clear?
Thank you. Thank you. Please proceed.
This is my disclosure, and my talk will be about 5 items. First, the revolution of hormone positive HER2 negative luminal type advanced breast cancer. The journey started with the approval of tamoxifen in 1970s, then with the introduction of aromatase inhibitor and the superiority over tamoxifen. Then fulvestrant came with its high dose 500 milligram in 2010. And during the last 10 years, there was a revolution of treatment by adding targeted therapy to hormone treatment. It started with mTOR inhibitor in 2012, and the second targeted therapy, our topic today, CDK4/6 inhibitor, then alpelisib, the PI3K inhibitor. And this is an old trial, but I just want to highlight about the progression-free survival tamoxifen versus about 9 months for letrozole. Then we have a multiple trial comparing tamoxifen versus anastrozole and exemestane. I just want to say that with this trial, the best median progression-free survival was not exceeding 12 months, and the overall response was ranging from 30 to 40% only. So we at this time need or we have an area of unmet need. By the introduction of fulvestrant, the progression-free survival was quite a little bit higher, up to 16 months, but didn't exceed the 2 years. So we have now the CDK4/6 inhibitor data, palbociclib, abemaciclib, and ribociclib. And because of time, I will not go through the mechanism of action. It actually inhibit the cell cycle by inhibiting going from G1 to S phase to introduce cell apoptosis and inhibiting cell proliferation. And we have now 3 approved CDK4/6 inhibitor, the 2 similar one, ribociclib and palbociclib, and 1 different instruction, abemaciclib. And this difference reflected in the dosing, as we have ribociclib and palbociclib given in an intermittent course, 3 weeks on and 1 week off. In comparison to abemaciclib, it is given in a continuous way with no drug holiday. This slide showed the 7 approved or the 7 phase 3 trial evaluated CDK4/6 inhibitor, either in first-line treatment. We have 5 trials, MONALEESA 7, MONALEESA 3, PALOMA 2, MONALEESA 2, and MONARCH 3. We have 3 trials in second-line or hormone resistant, PALOMA 3, MONARCH 2, and MONALEESA 3, as it includes the first-line and second-line too. And you can see that the overall response rate with adding of CDK4/6 inhibitor in all of this trial in the first line or in the second line was improved. And now we achieved more than 50% overall response rate in comparison to the history of 30s or 40s with hormonal treatment alone. And as regarding the progression-free survival that was at the best result of the Falcon 16 months is now reached at the first in all of the first line trials up to 28 and even in 33 months in Mona Lisa 3. So we have a doubling of the progression-free survival in the first line with adding of the CDK4/6 inhibitors. And also in the second line, all of the 3 trials showed a significant prolongation of the progression-free survival treatment and the improvement of the progression-free survival reaching up to or exceeding the 2 years of median progression-free survival. And this is the 3 randomized trial in the second line with improvement of the progression-free survival also. But this 3 trials in the second line has a different patient population. In Paloma 3, we have a heavily treated patient, and also 1 line of chemotherapy is allowed. And in Monarch 2, we have only allowed 1 line of hormonal treatment in the advanced stage, and the Mona Lisa 3, including both the first line or the second line hormonal treatment. So what about the abemaciclib trial? We have 3 trials. The first one, Monarch 2, it is designed to test the efficacy of abemaciclib in hormone-resistant patients, either primary or secondary resistant. And the patient were randomized to receive either abemaciclib in a dose of 150 milligram twice daily in a continuous way, plus fulvestrant versus placebo and fulvestrant. And the data of the overall survival of Monarch 2 was published or discussed in the ESMO 2019, and it was for the first time and ever in this group of patients or the advanced luminal type breast cancers, there was a significant improvement in overall survival with 9.4 months overall survival benefit, as the median overall survival for the combination abema fulvestrant was 46 months versus 37 months for the fulvestrant alone. And this improvement in overall survival was constant among all the subgroups, including those with more poor prognostic, those with visceral disease and primary resistant, even do better with the adding of abemaciclib. And this is the curve showing the improvement in overall survival in all sites of metastasis, and also in the patient with secondary resistant and those with especially with primary resistance. And one of the very important endpoint is time to chemotherapy, as it is not important to us only as a physician, but also for the patient. It's very important for the patient to delay chemotherapy as much as we can. The adding abemaciclib to fulvestrant improve or delay time to chemotherapy with a median 15 months versus 22 months. Actually, the timing is doubled. And about the toxicity, we have a common and famous adverse event for abemaciclib, diarrhea and neutropenia. But you can see that the percentage of diarrhea is, yes, high, 87% of patients, but the percentage of grade 3 is only 14.5 with no grade 4. Neutropenia was about 49%, and this percentage of neutropenia was the lowest among the other CDK4/6 inhibitors. And of course, diarrhea is a common adverse event, but its percentage as grade 3 is quite lower. And the occurrence of diarrhea is mainly at the beginning of the treatment, first 3 to 4 months of treatment, and decreasing with time. So we have a positive trial with improvement of overall survival, and especially for those with poor prognostic patient, visceral disease and primary resistant, and also the progression-free survival was significantly higher with a significant delay of time of chemotherapy. This is Monarch 2. Monarch 3 is designed to test the abemaciclib in the first-line treatment or hormone-naive patients, and patients were randomized to receive abemaciclib with its traditional dose plus AI, letrozole or anastrozole versus anastrozole or letrozole versus placebo, and the progression-free survival was actually doubled versus hormonal alone from 14.7 months up to 28 months for abemaciclib plus aromatase inhibitor. And this improvement in progression-free survival was constant also among all the subgroup of patients, and also it delayed the time of subsequent chemotherapy, and this significant delay was also among all the subgroup of patients. So we have a positive trial improving progression-free survival and overall survival, and we are waiting for the data regarding the overall survival. Then we have Monarch 2 trial. It is a phase 2 trial. It is unique for abemaciclib as it is the only CDK4/6 inhibitor that was tested in the as a single agent CDK4/6 inhibitor in heavily pretreated patient with an overall response rate of 26%. And the famous questions is fulvestrant versus anastrozole, or fulvestrant is still superior over aromatase inhibitor as in Falcon trial in the era of CDK4/6 inhibitor. This was answered in this randomized phase 2 trial published in or discussed in the last ASCO, comparing palbociclib fulvestrant versus palbociclib letrozole. And this trial showed a non-superiority of fulvestrant versus letrozole palbociclib. And this trial, although it is a negative trial, but its result is a positive result, as we know that fulvestrant is no longer superior to aromatase inhibitor in the era of CDK4/6 inhibitor. And the final one, does all CDK4/6 inhibitor result in an improvement in overall survival? I have said that Monarch 2 published its result regarding improvement for the overall survival for the first time in the ESMO 2019 with a 9.4 months overall survival benefit. And also in the same conference, Mona Lisa 3 published its result with an improvement, a significant improvement in overall survival in second-line treatment. And we have the third one, Paloma 3. Its result is before the other two trial in 2018. And although there was a numerical difference in overall survival, but the data was not significantly, the overall survival was not significant. And from the solid data to the real world, this is one of our cases in Electricity Hospital that was treated with CDK4/6 plus hormonal, and you can see that the disease was advanced breast, locally advanced lung, liver, and bone. And after 4 months, the PET-CT is almost disappeared, or the tumor was disappeared. And the patient is still ongoing on treatment until today, and she is maintaining her response. And this is not the only patient. This is the story of CDK4/6 inhibitor in most of our patients. And so thanks, Lily, for giving us abemaciclib. And thank you all for your attention, and thank you.
Thank you, Professor Nair, for your elegant, comprehensive talk. We have two questions. The first one, now we are in the era of COVID-19, and the presenting symptoms is diarrhea. Is there any international recommendation with Verzenio in this era?
I don't know if there is any international guidelines regarding in COVID era, but I mentioned that the incidence of diarrhea, of course, it is high, but the grade 3 is not of this higher it is about 8 to 20% of patients. And we can guide it with we can teach the patient how to use the lopramide with the drug, and how the best treatment and not to go into grade 3 diarrhea.
Okay. In oligometastatic patient, do you have any evidence of subgroup analysis like that supporting adding CDK4/6 inhibitor to hormone therapy? Is there any progression-free survival
for oligometastatic?
In oligomets, especially we have a data supporting that fulvestrant achieved a very good PFS for those patients. What do you think?
For bone metastasis?
Yeah.
In Falcon trial, yes, but Falcon trial had no an overall survival benefit.
Yes.
We have an overall survival benefit from MONALEESA 3, and we are waiting for the 3 trials in the first line treatment. So we are not supporting CDK4/6 inhibitor only for the progression-free survival, but also for the data regarding the overall survival.
Okay.
Even in oligometastatic patients.
Okay. Thank you, Dr. Noel. Now the floor for dear Professor Dr. Tariq Hashim.
Good evening, everybody. First, I wish to thank all my friends and colleagues at Ain Shams Clinical Oncology Department, Professor Lubna Al-Arab, and I wish to thank Lily team in Egypt for giving me the opportunity to share this session. I think we'll start this session by Professor Amr Sa. He is a professor of clinical oncology at Qasr Aini Center of Clinical Oncology. And the title of his talk is Second-Line Treatment in Patients with Metastatic Gastric Cancer. Professor Amr?
Yeah. Hello. I am very glad to be with you. Thanks a lot, Dr. Tariq Hashim, for this nice presentation and invitation for me. Thanks a lot for the organizing committee to this nice invitation. My slides here. Yeah. That's why.
Yes, sir. Please proceed.
Yes. My talk, I have to, first of all, I have to thank Lilly Company for this nice invitation. My talk today will be on the second-line treatment of gastric cancer. This is my disclosures. How we can treat gastric cancer? First-line treatment is usually the combination of platinum-based and fluorobimidine, either cisplatin or oxaliplatin, plus capecitabine or fluorouracil. And we have to start by this trial, TAX 325 international trial, containing patients from Europe, from America, from Asia, dealing with the value of adding docetaxel to the combination of cisplatin plus fluorobimidine. You have seen here the benefit is only less than 1 month. With the addition of docetaxel, we have median overall survival of 9.2 months. And for the combination of 2 drugs, 8.6 months. So the addition is only less than 1 month, although it is significant, but the value is low value. And look to the high toxicity profile with the addition of docetaxel. In my opinion, I have to start with the combination of cisplatin, fluorouracil or oxaliplatin plus fluorouracil FOLFOX, the major famous combination for this first-line treatment of gastric cancer, rather than to start by triple therapy. Before starting triple therapy, you have to mention the details of this trial to any patients with good performance status going to suffer from this such toxicity. For the group of patients with HER2 positive, the FDA approved trastuzumab in combination with fluorobamidine and platinum. For this type of patients, we have a significant improvement in median progression-free survival and also marked improvement in overall survival. For the first time, we exceed the median overall survival above 1 year, 13.8 months for patients with HER2 positive. And so from 2010, we give trastuzumab in combination with capecitabine and cisplatin for this category of patients. For the second-line treatment, we have to start from a phase 2 trial over 40 patients randomized to irinotecan or post-supportive care. We have a significant improvement in median overall survival with the addition of irinotecan. So irinotecan from 2011 became available as a second-line treatment after failure of fluorobamidine plus platinum. The same with docetaxel. Docetaxel versus best supportive care, we have improvement in median overall survival. In a larger trial, over 200 patients, docetaxel, irinotecan were given to patients after failure of first line versus best supportive care. The addition of chemotherapy provides significant improvement in overall survival, but we have no difference between docetaxel and irinotecan. So we can give docetaxel, we can give irinotecan. What is best, to give irinotecan or to give paclitaxel? Head-to-head comparison in second-line treatments. Paclitaxel versus irinotecan. The result is all the same. The same overall survival between paclitaxel and irinotecan. And so we have 3 drugs given as a monotherapy with the same results. Paclitaxel, docetaxel, and irinotecan. The 3 drugs are the same. And we have the anti-vascular anterior growth factor receptor. Yes, here is a difference between ramucirumab and bevacizumab. Here is ramucirumab, it blocks the receptor, while bevacizumab, it blocks the soluble part of VEGF. Here is the difference. Ramucirumab is humanized monoclonal antibody against vascular growth factor receptor 2, while beva is against the soluble part. For the first time, we have a biological drug which approved for the second-line treatment as a monotherapy. Ramucirumab versus best supportive care without chemotherapy. We have a median improvement in overall survival, and the drug is approved as a second-line without any chemotherapy. So it's an active drug. And here is the most important drug in second-line treatment, Rainbow trial. For patients after failure of platinum and fluorobamidine, patients were randomized either to giving ramucirumab plus paclitaxel or paclitaxel alone. And we have a significant improvement in response rate, nearly double the response rate from 16% with paclitaxel up to 28% with the combination treatment. And definitely we have significant improvement in progression. About the toxicity, we have nearly the same toxicity of adding ramucirumab to paclitaxel alone, except for 2 things. For the fatigue, it's 12% grade 3 fatigue, 12% versus only 5% with paclitaxel alone. And we have, yes, leukopenia and neutropenia, significant rise of neutropenia and leukopenia versus giving taxol alone. Here it's about the same toxicity profile like paclitaxel alone. And if you ask me about the toxicity itself of vascular anterior growth factor receptor inhibitor, we have bleeding or hemorrhage in 4%, we have proteinuria in only 1%, hypertension in 15% only, and we have nothing regarding venous thrombosis or arterial thrombosis, the same as paclitaxel. So the drug is a combination of ramio plus taxol is very safe combination. And look for the quality of life, which is the main issue for patients with gastric carcinoma with a short median overall survival. Overall, we have improvement in quality of life regarding global health status, physical function, pain, fatigue. So the combination gives more overall survival benefit and more quality of life, which is the important 2 factors for dealing with palliative treatment of gastric cancer. And we have to consider that the patient with HER2 positive receiving trastuzumab plus fluorobamidine platinum in a second line, we can't go for trastuzumab in combination with chemotherapy. This trial is very important trial, T-ACT study. When patient with HER2 positive receiving Herceptin plus Fulfox, for example, and after failure, you can't go for Herceptin plus Taxol, for example. You have to consider the standard treatment. Here in this trial, the addition of trastuzumab to paclitaxel did not give any significant improvement in progression-free survival and overall survival, and looked at the response rate 32 versus 33. So there is no data to confirm or to support trastuzumab beyond the progression. Go back to the standard treatment for patients with HER2 positive. What about the immunotherapy now? Keynote 6.1 is very important in second-line treatment. Patients after failure of fluorobamidine plus platinum randomized to either pembrolizumab or paclitaxel for patients with positive score 1 or higher. We have seen no benefit of pembrolizumab median overall survival 1.5 months and paclitaxel 4 months. There is no benefit at all. And overall survival, the same overall survival. There is no benefit, but the curve is doubling due to some sort of patient, some type of patient, MSI high patients. And look at the response rate. For pembrolizumab, it's only 16%. For paclitaxel, it's 14%. Yes, the response for patient with response for pembrolizumab, it's more durable, 18 months versus 5 months only. And look for this category of patients. Patient with MSI high, it's very important when you have this type of patient to give pembrolizumab single agent with a response rate 47%. About 50% of patients will respond to pembrolizumab versus only 17% to paclitaxel. For that reason, this is the conclusion of my talk about second-line treatment. We have to know the type of patients, you have to know the prior therapy, and the financial status of the patient was very, very important. If your patient is well supported financially, we have to give Ramio plus paclitaxel. Otherwise, we can give single agent docetaxel, paclitaxel, irinotecan, or Ramio in some sort of patients who cannot tolerate chemotherapy. And don't forget the category of patient with MSI tumor, which can benefit from pembrolizumab alone. Thanks a lot.
Professor Am, thank you so much for this very comprehensive presentation. And you have just told me that because of the interest of time, there is no time for any questions.
Thanks a lot.
Okay, thank you.